Thanks, Jeremy. So we have time for a question. All right, then I will take the prerogative to move on to the next speaker so we can catch up for the lunch lines. So our next speaker is Leonard Glantz. Leonard is professor of health law, bioethics, and human rights at BU's Schools of Public Health and Law.
Thank you. Thank you very much. I am going to use some PowerPoints, although I usually don't, because I'm talking to like doctors, and I figured without PowerPoint you won't believe anything I would say. So I'm going to want to talk about the ethics of standard of care research in the context of the doctor-patient relationship. And I want to do that for a couple of reasons, as I will explain in a moment. The first point that I had planned to make, but it's already been made for me, is that there's nothing special about standard of care research. And the reason why I say that is because the discussion about informed consent forms being too long and what's a reasonably foreseeable risk has nothing to do with this. That those are like discussions that have gone on forever, that the consent forms aren't too long because of this guidance. So consent forms stink. Okay, we agree with that. So my perspective is that we should do away with consent forms, but that's a different conference, right? What we need to do is a component analysis of what we're talking about and the issue here. And the issue isn't how long consent forms should be, and the issue isn't what's reasonably foreseeable, because the standard of reasonable foreseeability is a standard that applies to all research. The question of and the idea that standard of care research, by using that term, has some sort of moral or ethical force, I think is incorrect too. The fact that we name something doesn't tell us anything about its ethics or anything, or really anything else about it. It's just a name. So if it's research, the question then becomes, in what way should we apply ethical norms to it? What are the generally applicable ethical principles that should be applied to this sort of research? The current discussion, I think, puts an irrelevant and excessive emphasis on the risks of research. That we act as if that's the problem and that's why we regulate research. We do not regulate research because it's riskier than standard of care. That's not the basis for research regulation. In fact, it's often the case that research and standard of care, that the research risks are the same or less than the intervention that would ordinarily be had, but that's not the issue. So if a physician does a liver biopsy on somebody for therapy, or a physician does a liver biopsy on somebody for pure research purposes, the risks are exactly the same. We don't regulate one differently than the other because the risks are different. We regulate them for really quite different reasons. And the reasons has to do with respect for persons and protecting the rights, not just the welfare of individuals. So I think we need to go back to the basics of why we have research, why research ethics has been developed. And the reason is because the research subjects are used as a means to an end. As it was said in the olden days, that they are not an end in themselves, that it's using people in order to get knowledge that will help somebody else. And what research ethics is really about is that people should know that. So I think that we should change the focus from what risks need to be disclosed to what needs to be disclosed. Or whether or not it needs to be disclosed in the risk section or whether it should be disclosed in the purposes section. That seems to me to be, a procedural problem as opposed to a substantial problem. So here's why research has come to be regulated differently. So in medical care, there are physicians and patients, and patient well-being is the sole goal of this dyad. The patient expectation is that the doctor's judgments will be made in her interest. This is not flipping a coin. The fact that the physician doesn't know with certainty what the best treatment is doesn't mean that the physician isn't acting solely in the person's best interest, that is the goal. So I'm not talking about subjects, and I'm not talking about physicians. I'm talking about patients. I'm talking about a patient and a physician. And the reason why I'm discussing it in this context is because so much of this research is done in the context of a physician-patient relationship. Patients go to doctors. Patients' and physicians' goals are identical, and there's consent. On this side, there are researchers and subjects. And the difference between a doctor and a researcher and a patient and subject is a morally important different. It's not just a name. And the goal is new knowledge. There's loyalty to a protocol in addition to loyalty to a patient. The treatment decisions are not made solely in the best interest of patients. This is flipping coins, or it could be flipping coins, depending on how it's done. So the stuff on the right-hand side is not done for patients. The stuff on the left-hand side is done for patients. So I've been told that this is terrible. It's terrible to say this, because it makes it look like the researchers are just terrible, evil, nefarious people, and doctors are caring and good people, and that this is just a terrible thing to say. And it's only a terrible thing to say if you believe there's something inherently wrong with research. There's nothing wrong with the right-hand side, as long as the person knows that's what's gone on. Right? That the purpose of informed consent is to make sure the person knows this, that there is now a difference, that they've moved from a person who's solely acting in their interest to a person who has some other interests. By definition, when we're dealing with a doctor-patient relationship, a person has gone to a physician with a problem or with a purpose, and what they expect is for the physician to exercise their best judgment. That's what they expect. They don't go looking for a particular blood pressure medication. They don't go looking for a particular procedure. They go to physicians because physicians are supposed to be learned. At least that's the rumor. And that, they did things like go to medical school. They did like residencies. They might read a medical journal. So they might not have perfect knowledge. But the thought that they don't have perfect knowledge means that they have no knowledge is just a gross exaggeration. So the question isn't if this person went to a different doctor, might they have gotten a different treatment? That strikes me as not an important question at all. The point is that the person went to this doctor and is expecting this physician to exercise her judgment, and that's where she ended up. And when there's a departure from that expectation, a completely reasonable expectation, that has to be agreed to, that departure. In a sense, what the consent in this circumstance is to relieve physicians of their obligations to make judgments. That up to this point, physicians have obligations to make their best judgment for the person. And now the patient is relieving the physician of that obligation. So this leads to the broader question, since it's not just risk, is what is it that persons need to be told? So I have a problem with the term foreseeable risk too. And I had a problem with the term foreseeable risk before this guidance. And the problem with foreseeable risk is that, someone once said, on a clear day you can foresee forever. And it's true that, foreseeable risks are anything that you can foresee. That's not a very narrow population of risks. The early consent cases dealing with treatment discuss material risks, that the case law actually says there's no way anybody can discuss all risks. What you discuss are material risks, and that the material risks are risks that reasonable people would think might affect the outcome of a person's decision. So one of the things that might affect my outcome or your outcome is a doctor saying, if you agree to be in this research study, then you won't know, you will not get the drug that I ordinarily use. And that's worked pretty well. But I don't really know if it's the best drug, but you're not going to get the one that I ordinarily use. You might get it, you might not get it. And you're not going to choose it, and I'm not going to choose it. And you're not going to know what drug you have, and I'm not going to know what drug you have. That's a pretty stark departure from the ordinary doctor-patient relationship. And it's up to you to decide whether you want to do it after talking about the various options, of course. A person might find that to be quite material. They would say, well, I prefer your experiences. So is that a good choice? Is that the best choice? The doctrine of informed consent is not about making the best choices. It's about making a choice and having adequate information to make that choice. So we need to, and again, this is really the concluding point that I want to make, is that there is nothing special about standard of care, and there are different kinds. So I think Charles' discussion of component analysis is very informative and very interesting, but the treatments themselves, we don't know anything about them, right? Just like in all research, as Jeremy pointed out, there's riskier and there's less risky research. The fact that it's standard of care doesn't actually tell you anything about what needs to be discussed or what the moral relevance is of the distinctions. If one is comparing levels of exposure to radiation for childhood cancer, or that one is looking at watchful waiting for prostate cancer as opposed to prostate surgery, or if one is comparing surgical approaches to medical approaches, that those are different. Those are not like, what bicycle do you ride? You know, what kind of bike do we use at the gym? That's like trivial. And the question of how much radiation you give is like important. And people could have, based on their own fears and their own concerns, a real opinion about which way they want to go. So it's not enough to say, so it's interesting that Charles said, but I still think we should get their informed consent. Okay? Even if there's this thing, I still think we should get informed consent, even though there were people who will argue it meets the standard for waiver. Right, that it's minimal risk, or there's no risk, or there's no thing, but we should get informed consent. And it's because it's different than those low-risk waiver approvable kinds of studies, that there are moral differences between a doctor acting on behalf of a patient and a researcher acting on behalf of a protocol. And it's essential for people to know that. Okay, so let me stop there.
Great, thank you. Wait, Chris. You got to ask questions. Any questions?
There can't be any questions.
No, there is one.
How can there be any questions?
Yes.
Hello, John.
Hey, how are you?
I'm
Thanks.
fine.
That was great. I want to follow up on your opening comment that you said was a topic for a different meeting, because I think it is relevant to what you went on to say. You said you wanted to get rid of consent forms altogether. Given what you've said about what the central issue to be disclosed is, that is, it's not about risk, it's not about whether it's standard of care, but it's something about the nature of the relationship. What would you replace a consent form with, or would it be the information that's in it, or are you just talking about?
No, what I would do when I'm like king of the world, you can vote for me for that, what I would do is do away with consent forms because they were a way of documenting. They're just supposed to be a documentation of the informed consent conversation. We know that they're not, right? That the consent form has no relationship to the discussion. So as a result of that, we focus on something which is sort of imaginary. It has, whoever said it, has gone from being an educational tool for potential subjects to a liability reduction tool for institutions. And it's like all forms. You know, the form you sign for a rental car is not there for you. It's there for Hertz. And the form that you sign for research now has nothing to do with you. It has to do with... And so if you want to... So what I think you should do is record the conversations. And that doesn't mean that everything should be listed. I think that by recording them, you know what was actually told. And I think by having the people who are doing the educating know that you can actually hear what they say will have an impact on it. So I'm with Jeremy to get a waiver from the secretary to do away with consent forms in a population and record these things, because the documents are useless. Everyone agrees the documents. I mean, I don't know anyone who's ever defended a consent form. So the question is, so why do we still have them? Yes, you look familiar.
Thanks, Leonard. Skip Nelson, FDA. A question about reasonably foreseeable. You clearly don't like the concept, but I'm wondering, there are two law professors on this panel, and I'm just curious, are there definitions of reasonably foreseeable from areas such as tort law, where if you failed to disclose a risk that was reasonably foreseeable, you would be considered negligent, other than material risk that would be in the informed consent setting?
Well, the reasonable foreseeable risk you don't see in tort law for disclosures. You see it in tort law for actions. And that the question is, and when you look at it, it's always based on something bad that's happened. So if you dig a hole in front of your house, right, and someone steps in it, the question is, was that reasonably foreseeable? And it's left up to a jury, that you have somebody you have an actual body that decides whether it's reasonably foreseeable, which we don't have here. So the term reasonably foreseeable, just like the term standard of care, is not a scientific term. That if you live in the world of law, you have to be willing to live with ambiguity. It's the way it is. That there are no randomized clinical trials in law. That it involves human activities and human judgment. So it means, you say to the jury, should this person have foreseen this? If they go 90 miles an hour and it's rainy, should they have foreseen they can kill somebody? The answer is sure.
First of all, I wanted to thank you, since I'm a physician, for recognizing the physician-patient relationship, albeit imperfect. It is different from the researcher's relationship. But secondly, as a physician-researcher, I think that one of the things that we sometimes forget is that researchers should at least feel some responsibility to their subjects as well. And we sometimes, by making a dichotomy, perhaps make things black and white that sometimes are gray in terms of the researcher's obligation to have some interest in it, to have some regard for the best interests of their subjects, sometimes even if that causes them to deviate from a protocol or do something else.
Well, what I would say is that the standard for researchers is not to act in the best interest of their subjects. Some may, but that's not the standard. If it were, then it would be hard to do randomization, and it would be hard to subject people to certain much riskier things. So if you use the example of high or low radiation for children with cancer, and you just randomize people into that group, their best interest isn't the question at that moment. You don't know what it is. Well, so I'm not. That's why I'm not saying it's nefarious. I'm saying it's a change, and I think that everyone needs to recognize that change, so that when you begin to randomize people into a study, that the patient needs to know that you are no longer acting as a physician acts. Physicians don't randomize people.
I think that, however, the researcher has a lot of obligation for safe design, best design, many things that are actually for the benefit of the subject, to reduce the harm to them. We've talked about that in the IRB context. And this is just personal. I think that there are actually investigators who do end up having to wear both hats and somehow manage to balance them, and that sometimes we don't recognize that.
Yeah, I'm with you 100%. All that I'm saying is that, well, my major point, is not all that I'm saying, is that people need to recognize they're wearing a different hat, and that the patients need to recognize.
Yeah, I keep a black hat and a white hat so that people know.
Yeah, or it could be like blue and green, just to be more neutral about it.